We have the world at our fingertips, inspiration in our touch, and power in our hands. Our hands, gentle enough to hold the next generation, yet strong enough to build movements that can change the world. Our hands can build relationships, frame ideas, and empower communities. We have the ability to share and imagine, create and comfort, love and heal the world around us. And it doesn't stop there. Right here, in our hands, we have the power to save a life. If you see a teen or adult suddenly collapse, call 911 and push hard and fast in the center of the chest.
The power is in your hands.
Hi, and welcome. Thank you for joining us today to learn about CPR and the chain of survival. Today, 70% of Americans say that they feel helpless to act during a cardiac emergency. We're a nation of bystanders that lack the knowledge to act and save a life, but by joining us today, you're helping us change into a nation of lifesavers. The American Heart Association has set a goal of doubling the out-of-hospital cardiac arrest survival rate by the year 2030, but we can't do it just by ourselves. The more people who learn CPR and understand how to identify a cardiac emergency and feel equipped to step in to save a life, the closer we get to this goal. Before we begin our conversation, I just want to take a moment to thank Alnylam Pharmaceuticals for their amazing support of the mission of the AHA by bringing this program to companies like yours and community members across Greater Boston. We're thankful for their support and commitment to giving back. One last housekeeping item. Today we'll raise awareness about bystander CPR and AEDs. We'll help achieve our goal of having one person per household educated about hands-only CPR. We'll make companies and employees aware of how you can take the next step to get certified and trained in CPR and remove barriers that prevent people from acting in an emergency. Please understand that this presentation is an awareness activity. It is not a proficiency in CPR or certification program. We'll be providing some additional information for those of you interested in learning how to become CPR certified and for hands-on practice at training centers following the presentation. But for now, I'd love to get started. I'm Rachel Agemian. I am the Associate Vice President of Development here at the Heart Association in Massachusetts. And joining us today to educate us and inspire us is Dr. Kamar Brown. Dr. Kamar Brown is a heart failure cardiologist at Mass General Hospital. So thanks for joining us today, Dr. Brown.
Thanks for having me, Rachel, and it's good to really be a part of the session today. So we're pretty much here to talk about CPR, and hopefully we'll be able to get through the session in a way such that everyone on this webinar will feel somewhat more empowered to save a life if they have to.
Yeah, absolutely. And Dr. Brown, I know that you've really been a local leader for our team of the Heart Association here in Massachusetts over several years, many years at this point, with the public education that we do around how to perform CPR, how to identify when CPR is important. And so I know we were going to start today with just allowing you a minute of sharing a personal story around why this is so important to you. So I'm just going to share up your screens a little bit and would love for you to talk us through some of that personal story.
Yeah, absolutely. So while you're pulling that up, Rachel, maybe I can start by saying that I really got into this work because I had a close colleague here who, as a doctor, was also a victim of a cardiac arrest, and we'll go through that in a little bit. But essentially, the big deal about this is that not many people survive an out-of-hospital cardiac arrest. And what we saw in the previous slide is that the majority of cardiac arrests are happening outside of the hospital. 70%, up to 72% of cardiac arrests are happening And in a room right now, we have 53 participants on this call. I'm just looking at the numbers here. And if we look at that 1 out of 10 number, about 5 folks will survive an out of hospital cardiac arrest with the status quo as is. And those numbers absolutely need to change. We need to be able to save more lives. And this is why this is really, really important, not only to pay attention and empower yourselves, but also to spread the word in the community. So 1 in 10 will survive an out of hospital cardiac arrest. And the main reason is there's just lack of awareness, lack of bystander knowledge on how to administer a cardiac arrest. And on top of that, there's a discomfort that we know exists in the community in administering cardiac arrest care.
Right, absolutely. And I know, we said earlier that 70% of the nation, reports saying they're uncomfortable to recognize and jump in. And we know that, that's just a comfort level. That's not even whether or not when faced with an emergency, we feel confident enough to step in sort of that freeze state of shock.
Right. So I started by mentioning a close colleague of mine who, while training to be a doctor, was a victim of a cardiac arrest. So he was on the basketball court with his colleagues and pretty much fell out of the air, mid-air. And he was lucky in the sense that the folks that he was surrounded by were training to be physicians and were equipped with the skills necessary to administer cardiac arrest care, so CPR. And ultimately, he he got CPR and then was admitted to the hospital for several weeks in the ICU. So the picture here shows Dr. Anezi Uzendu, who is now a cardiologist today. And that's him after his cardiac arrest, intubated, sedated, in a coma, and this lasted for several weeks. So if we want to just advance to the next slide, there's a video that should come next detailing Dr. Uzendu's story, and I just wanted to share that with you.
Great.
In basketball, each bounce, each dribble keeps the game going. In life, it's a different beat that has to stay in rhythm.
People don't survive what I survived.
Anezi Uzendu was shooting hoops at a local gym when all of a sudden he hit the floor.
While I was playing, I just kind of collapsed and was found to have cardiac arrest. My heart was quivering. Just was a rhythm that wasn't compatible with life.
He was rushed to a nearby hospital and soon after brought to UAB.
When we transferred him to UAB and I spoke with the cardiologist, they told me that he had a less than 10% chance of even surviving this. He had complete multi-system failure, so almost every organ in his body was not working.
Uzendu had been in the cardiac care unit before for a much different reason. Here, Dr. Uzendu, an internal medicine resident at UAB, was now the one being cared for.
I was at the UAB CCU that I work at all the time, and I had great nurses and doctors that I've worked with all the time as colleagues taking care of me now as a patient.
He stayed in intensive care for days, fighting for his life. And every step of the way, his UAB family was always by his side.
The first time he just squeezed our hand. In the excitement and celebration in the CCU, as you can imagine, of just knowing that he was responding.
In just 6 weeks, he recovered and was back at work.
Just seeing that, when things were that hopeless, that people prayed and people had hope, and they called to God really for a miracle to happen. And it did.
Dr. Uzendu finished his residency program. He now plans to become a cardiologist, and he says his heart will always be in Birmingham.
I hope he never forgets us, because I will miss him dearly.
When I came here, I didn't know anyone, and I feel like I'll be leaving with a whole new family.
So that was Dr. Uzendu's story, and essentially what he's been able to do was launch a program called the Make BLS Basic program, which is how I got introduced to CPR education. I've been doing this for the past 5-6 years now across Boston. And the ultimate goal is to raise awareness. We go into barbershops, we go into schools, we go into churches, we go all across the city, sort of giving as much information as we can, and actually doing on the ground training with mannequins, and get people going and excited about being lifesavers. So it's really important to get involved here, so that if the unfortunate incidents were to arise, and someone passed out and needed CPR care, everyone in this room, in this audience today, would be able to deliver that care.
Yeah, I appreciate that. And I really appreciate you sharing your colleague's story. I think, you mentioned just there, making sure that everyone who has a cardiac arrest has access to intervention and has access to this emergency care. And, at the Heart Association, we talk a lot about how in cities like Boston, or even just if we look at in the greater Boston, or the Eastern Massachusetts area, we know that response rate or access to someone who feels comfortable to step in, it's not the same everywhere. There are disparities across the community. I know that's, you mentioned going into barber shops, you mentioned going into places of worship. And I know we've done some of that work in collaboration as well with the Heart Association and your colleagues at MGH. And so I just, obviously it's a big topic we could talk about for a lot more time than we have today. But I'd love for us to just touch on a little bit about, if we look across these different neighborhoods. I know at the Heart Association, we focus on Hyde Park and Mattapan and Dorchester and East Boston and Roxbury. We focus on major cities, a lot of gateway cities like Lawrence and Lowell and Brockton, as being areas with less equitable access to care. So if you could just kind of give us that high level understanding from the physician's perspective of what these disparities are and the barriers that they create to everyone having this equal chance at a long and healthy life. And I'm happy to pull up some of your slides whenever you want.
Yeah, that'd be great. If you don't mind pulling up the slides, but it's a big issue. I would start by saying that the same areas that have poor EMS to victim time are the same areas that have the highest risk factors for cardiac arrest. So things like hypertension, diabetes, obesity, coronary disease tend to predispose folks to negative sort of remodeling of the heart. And that's when we see cardiac arrest happen, when there's lots of scar tissue in the heart. And these are the biggest risk factors for developing scar tissue in the heart. And when you look across Boston, for example, and we can advance to the next slide here, just advance to the next slide, Rachel. The areas that light up the most based on this heat map of Boston are the same areas that Rachel had mentioned, the Roxbury, the Mattapan, the Lynn, that have the highest prevalence of hypertension. And hypertension is the biggest risk factor for developing heart disease, heart failure, and ultimately cardiac arrest. Diabetes is another one of those risk factors. And if you look at diabetes, the number one cause of death in patients with diabetes is sudden cardiac death, right? And we know how prevalent that is. So we really need to get our pulse on this issue in order to tackle the disparate outcomes. 1 in 10 surviving, and those numbers are even worse when we look at these communities. These communities are typically comprised of minoritized populations that are oftentimes under-resourced and have lack of access to adequate health care. And this is why this is a passion project of mine, to get the word out, to make sure that everyone in our communities across Boston will have the same access to care.
Yeah, and I know, I know that our team, when we're talking with companies, who want to help better the health of the city and the communities where their employees live and work. I often share, and I hear a lot of my colleagues share, that if you just look at the Back Bay neighborhood, and then you look at Roxbury, and there's a 3-mile difference, the life expectancy rate changes by 15 years. It's within the same city, near hospitals like Mass General and Brigham and Boston Medical Center, all these amazing high qualified hospitals, yet we're still seeing this huge disparity in access to that longevity of life.
Yeah, that's a really important point, because this becomes important. Just speaking to what I do as a subspecialist here in cardiology, I'm a heart failure transplant cardiologist, right? And we're seeing lots of young Black men, for example, if we look at this blue line up top, getting diagnosed with heart failure, sort of at a younger age, having more hospitalization and ultimately dying more than any other group from heart failure, right? And dying from heart failure will include dying suddenly from a cardiac arrest, for example. And if there's no one in the community to rescue someone, if they suddenly pass out in the grocery store or in their right place of work, then we're not there. That's not justice, right? We got to make sure that everyone is on top of this and know what to do when the time arises to rescue someone. If we advance to the next slide. The lack of access reaches way across the health systems here in Boston. And what we know is that when the time comes for one of my heart failure patients to need heart replacement therapy, which means that the heart no longer can keep up with the body's needs, and we have to take that old non-functional heart out, put a new one in, the access to even heart transplants are dramatically disparate in Boston. 85% of hearts go to white patients here in Boston, and about 6 to 7% of hearts will go to Black and Hispanic patients across the city. And this is not a center-specific phenomenon. Just wanted to point that out. This is a ubiquitous problem across all major transplant centers in our city. Compared to New York, with a similar demographic, 26% of their hearts are going to Black patients. So there's some mismatch there that we're not truly capturing. And that's another one of my missions, to understand what's going on there. So we're saving as many lives from all the communities as we can.
Yeah, I think we had pulled up this photo here to share, and I thought we could take a minute or so to talk about the clinics in Chelsea, because I know that this is something that you were able to come to the Heart Association about. And one of the things that we get to do as the Heart Association that I'm really proud of, and really grateful that the association focuses on is looking at, we are not a hospital, we are in partnership with all these hospitals in our great cities, and we have the science and the resources in partnership with the community support that we have to find out where are these cracks of disparities, where are these pockets of population that are not having the same kind of access to care, and how can we come in with these unexpected or more creative ways to help sort of lift everyone up to the same level of access. And so, Chelsea isn't a neighborhood we've talked about yet, but definitely a historically under-resourced community in the Boston area, even just in terms of ease of public transportation to the hospitals. And so we've got maybe 2 or 3 more minutes we can spend here before we switch topics, but just talk a little bit about this heart transplant clinic and sort of the why, connecting with us to find funding for blood pressure cuffs and scales was so impactful to the lives of folks here.
Yeah, thanks for. So what I've understood so far, based on the work that I've done, is that boots on the ground is very important, is essential in making sure that we're bridging these access gaps. And so what we ended up doing a couple of years ago was establish a standalone clinic, a heart failure clinic out in Chelsea, in order to bridge some of these access gaps, right? Hispanic, Black patients, refugee populations, we want to make sure that everyone has the same access. It wasn't an easy task. I'll start there, and I want to be as frank as possible. Money is always an issue, and resources are always an issue when we go into these communities. And luckily, with the partnership of the American Heart Association, we were able to even bring in blood pressure cuffs and scales to make sure that folks have access to even, right, when we're titrating some of the meds to make sure that we're rescuing these hearts, that we're watching the blood pressure and we're monitoring the weight. And these small interventions can go a long way in saving someone from even being hospitalized. And so I really, really appreciate the advocacy and the resources provided by the AHA, right, to get even scales and cuffs on the ground. I'll say that there's much more that needs to be done, but it's a great starting point. And with the partnerships that we've built with the AHA, I think we're heading off in the right direction here, and we have a solid foundation to begin with. These,
Yeah, we're always, sorry, go
I want to
ahead.
point out some of my colleagues here in the picture. This was
Sure.
opening day at the clinic. And I just wanted to give recognition to just not a single person effort. This was done not only with help from the AHA, but took a lot of folks and stakeholders here at MGH to get this launched.
Absolutely. Yeah, and we're so grateful again just for the collaboration and the ability that we have to tackle these big issues, you know, together. And I know we could probably spend another hour talking about Boston and talking about, you know, health equity and access and all of these passionate topics for you. But I do want to make sure, and I know you mentioned this at the beginning, that everyone who is here today with us leaves with a solid understanding of how to identify when somebody needs to have bystander CPR performed, and what to do in the case. So I'd love to start by just asking you a couple basic questions that we often get around CPR, and you know, then we can jump into what is the chain of survival and the do's and don'ts of CPR, and I know share a demonstration later. But let's just start with the real basics. Oftentimes we hear, you know, as someone without a medical degree, we hear the terms cardiac arrest and heart attack talked about a lot. And I wonder if you could just start us very simply with what is the difference, or what is a cardiac arrest and what is a heart attack?
Yeah, so I can certainly clarify. So a heart attack is essentially a phenomenon that happens when there are blockages in the coronary vessels that supply the heart muscle itself with blood, nutrients, oxygen. And to take a step back, I always paint the house like this, the heart like this. The heart is a house, and the house has several components that keep it functioning properly, right? You have the walls of the house, or the frame of the house, which is the heart muscle itself. You have electrical wiring that supply the house with electricity and energy. And then you have the plumbing within the house, all right? In a similar sense, right, the heart is comprised of the structure or the frame, which is the heart muscle itself. And then you have electrical wiring, right, that tells the heart to beat, right, and contract. And then you have the plumbing, right? The heart also needs energy, nutrients, blood supply to keep going. And it's the plumbing that gets clogged up when someone has a heart attack, all right? When the plumbing gets clogged up, a piece of the muscle does not get adequate blood flow. And so that part of the muscle starts dying off. Patients become quite symptomatic. Oh, I have chest pain. They go into the hospital and then get that part of the plumbing opened up.
Okay.
Usually you have a lot of time to respond when there's a heart attack. Patients are symptomatic and they'll be talking to you, going over their symptoms. The difference here is that in a cardiac arrest, the heart itself on a whole will start failing and stop beating. The plumbing shuts down, the electricity shuts down, and the walls stop beating, stop contracting. And when that happens, there's a lack of blood supply going to the brain, going to the vital organs. And so the first thing that the patient will do is pass out. So in a cardiac arrest, compared to a heart attack, you have minutes to respond. And after about 5 minutes of lack of blood supply to the brain tissue will now start dying. And the ultimate long-term sequelae of that is, if you don't rescue the heart in adequate amount of time, the body will start failing. So if a piece of the heart, a piece of the brain gets damaged, you'll end up with a part of the body not functioning well. And so there are long-term residual deficits that occur in cardiac arrest if folks aren't rescued in time. And God forbid, if they're not rescued at all, the patient will die in a matter of minutes.
Yeah, so I hear you saying time is the absolute essence, right? With a cardiac arrest, and I also hear you saying that is that sort of visible emergency moment. So a heart attack, that's a little bit more some symptoms. Maybe someone realizes they might want to talk to a doctor, whereas when CPR is needed, it will be somebody passing out. So can you tell a little bit more about when I see someone pass out, because we know that the majority of cardiac arrests don't happen in a hospital setting. It's going to be happening, in your home or in your place of worship or in your community center, in your school, in your workplace. If we see someone pass out, what do we do and how do we jump right in?
Yeah. So if you don't mind putting up the slides, because it's going to be important not only to hear my voice say this, but also important to see the visuals. The first thing you want to do is make sure that help is on the way, right? The main thing here is that if you're the only one that knows that this person needs help and you're trying to do CPR, you're going to get tired yourself, and that the high quality care that patient would benefit from by having emergency personnel come in and sort of take over and sort of bring them over to a tertiary institution to continue care, right? If that's not happening in the background, then we're doing that victim a disservice. So the first thing you want to do is make sure that help is on the way by calling 911. And then the next thing you want to do, especially if you're alone, is to jump right in. 911 is on the phone. They're telling you what to do, and going over stuff with you as well. And essentially, while help is on the way, you would be the one delivering CPR care. If there's another person next to you or multiple people next to you with the information that you'll get today, you want to be the leader. You're going to be the delegator, right, in the team. So 911, help is on the way, you're delivering CPR, but you're going to tell people around you to get an AED device, which is a device that will shock the heart back into its normal rhythm, if we need to, and we'll talk about that in a little bit. In a little bit. Let's now go over the do's and don'ts of CPR care. So if someone passes out, whether it's at home, in a grocery store, in a barbershop, etc., you want to make sure that that victim is on a hard surface, so not on the bed, not in a chair. Rest them on the ground and place the hand in the middle of the chest and start pushing hard and fast in the center of the chest. The hand positioning that you utilize is also essential. And what you want to do is make sure that that force, the vector of that force, is as pointed as possible over the heart and not spread out all over the chest. We want to be delivering chest compressions to the lungs. We want to deliver chest compressions to the heart itself. And with each compression, you're pretty much being a surrogate for the heart. You're squeezing the heart, and with every squeeze, blood gets delivered to the brain and to the vital organs. So those hands need to be as directed as possible over the heart. And I'm showing you here two different hand positions. The first is sort of the hands sort of spread out. right? The vector of the force is all over the chest. And then the next one is, right, you closing up your hand like this, and you're not really covering as much of the heart as possible. And so these green check marks, those are the things you want to do. You want to make sure that the heart is over the center and sort of covering the left side of the chest. You can either put one hand on top of the other or have one interlocked as depicted here in the picture. We go to the next slide. The next thing you want to do is use the heel of the hand here. I'm just going to move a little closer to the camera so you can see. If you're using the palm, sort of the center of the hand, there's a big gap there. And it's going to be difficult to really apply that force efficiently to the heart and to the chest. So you want to have as much contact with the chest as possible. And that's why the heel of the hand is essential to use when you're applying the force.
Yeah, and it's not, having been, we get certified on a regular basis as the AHA staff, and this is not a delicate thing. So that, that power that you have in that hand is so important, of you explaining how you are beating that person's heart. That takes a significant amount of force.
And I'll tell you this, I've done this a lot of times, unfortunately, in the hospital setting. And luckily, patients will have quick access to CPR care. And the amount of force that you're delivering is so much that you'll kind of hear ribs cracking, and right, it's really a lot of force. But I would rather have ribs that crack and break that will heal up in weeks to months in an attempt to save that person's life, because ribs will heal, but if that person doesn't get adequate CPR, they will die. The next thing you want to do is make sure that the shoulders are directly sort of over the victim, and that all that force is pointed right downward onto the sternum. So all of these positioning that I'm showing you here will allow for the best and most effective amount of force sort of distributed over the heart. The next thing here is that you want to make sure that the elbows aren't bending when you're compressing the chest, because each time if you bend the elbow, all of that force is going to be pointed to the elbow and be delivered to the elbow. The vector is pointed to the elbow. You want to interlock the elbows and make sure that all of that force is going down to the chest. Adequate compression is important. I know this is really hard to capture. And when we're delivering training, for example, we have these mannequins that are like specially designed, and I wish I had it here to show you today, but they're specially designed to click. So you'll hear a sound if you're actually delivering adequate compression, right? And what you want is at least 2 to 3 inches of compression, such that the heart is squeezing as much as possible. All that blood is leaving the heart, going up to the brain, the vital organs. And when you release, blood comes back into the heart, right? So that the next cycle of compression will have enough blood that's in the heart going up to the brain after the compression is done.
So you can't do it too hard is something that I'm hearing from you.
You
for the average person.
Yeah, you have to do it hard enough so that the blood squeezes and goes up to the brain and vital organs. But you have to allow enough recoil for the heart to fill back up with blood for the next cycle of compression to be effective. The cadence at which you sort of do the compressions is also important. If you're going slow and taking your time, right, you're not going to deliver effective CPR. So you want to make sure that you're squeezing at 100 beats per minute. And one trick that we oftentimes employ when we're teaching is to march to the beat of Staying Alive in your head. You remember that song, Staying Alive? I wish I don't have a good singing voice. I won't torture you guys today on the call. But if you go through and try to sing Staying Alive in your head, that will be about 100 beats per minute. For our younger folks in the audience, Crazy in Love by Beyonce is something that folks will also use. And then for the very young people in the audience, I think Baby Shark is
That
another
is
one.
correct.
Yeah, the Baby Shark song is another one that folks will use in their head when they're delivering compressions. We previously mentioned these AEDs, these automated external defibrillators. And what this device is, it's a device that will shock the heart. So it comes with these electrical pads that you'll place on the chest. And it not only delivers a shock, but it also recognizes the rhythm, the heart rhythm. And it's clever enough to know when to shock. So there are some rhythms that you shouldn't shock and some that you should. And the device is clever enough, and it actually has this, I don't know if it's AI. AI wasn't around when these were discovered, but ultimately you'll hear a voice telling you, going through the instructions, place pads on chest, detecting rhythm, shockable rhythm, stand back, and then you deliver the shock, and it will give you some time to take your hand off the device, stand back, and then it will deliver the shock. And this is very important. The reason I'm bringing this up today is that all of our institutions here, I know there are a couple of people on this call from various institutions, you want to make sure that you know where this AED device is in your various institutions. And if you don't know, you got to know today. Bring a bunch of people with you and show them where it is, because if your life needs to be saved, you want to make sure that your coworkers know where these AED devices are. So every institution needs to have at least one on a floor. So if you have multiple tiered building, or there needs to be an AED device there so that you can rescue the life. Essential positioning of the AED, the pads are important. And a good way to remember how to place this is if you draw the L on the chest, as I'm doing here, spelling out the word life. So the first pad will go sort of on the top right of the chest, and then the other pad will go sort of at the mid-axillary line is the technical term, but essentially at the mid-axillary line and then at the right clavicle. And this position will allow for the vector of the electricity, right, coming from these pads to go from top to bottom, and will sort of revive the heart if it's delivered efficiently back into its native electrical conduction. When you're delivering CPR and after you give the shock, the device will tell you resume CPR right away. All right, so there shouldn't be a shock and then you're just waiting around. You should just jump right back into delivering CPR. That's the most important thing there. And if for any reason, right, and this is what we're hoping for, the heart regains its native contraction and it's beating regularly, the patient starts waking up or the victim starts waking up, they'll let you know whether you need to get off, right? Because it's not comfortable to be pressing on the chest. So they'll start moaning and groaning, they'll start moving around, and that will be the first indication that their native contraction and conduction has been rescued by your CPR attempt.
Wonderful. We're coming up. I think the next slide we're going to do is a video that will demonstrate all of these techniques that Dr. Brown just walked us through. So you can really see someone, it's demonstrating also if you're alone, right? So I know Dr. Brown mentioned if you have a group of people, sending one person, go call 911, another person, go find an AED and bring it back. But what do you do if you're alone? And so this will also demonstrate, putting your phone on speaker next to the victim as you're talking to 911. And we need to move to that. We're coming up on our short time for our lunch and learn, but I wanted, right before we move to that, Dr. Brown, we are talking about hands-only CPR. I know the first time I learned CPR, there were a lot of numbers involved. It was X number of rescue breaths, and do you have a mask? And there were all these sort of, the victim may vomit, and it was really complex. And today we've just been talking about hands-only CPR. And I think for a lot of us who learned at first, trying to remember the numbers of how many chest compressions to breaths, just give us give us a quick, like, why are we talking about hands-only CPR?
Yeah, so I'll tell you that hands-only CPR is enough to rescue someone who's suffering from a cardiac arrest. And ultimately, what we want to do is be a surrogate for the heart. All right. Mm-hmm. Blood flow going up from the heart to the vital organs is the most critical part of the CPR delivery. And the mouth-to-mouth resuscitation became a huge problem, especially during the COVID era. Right, you talk about people being sort of uncomfortable delivering CPR to the victim. During the COVID era, this became a huge issue, sort of seeing a stranger passing out in the grocery store and trying to protect yourself as well. I think being able to only provide hands-only CPR, I think is what we want to do here, because doing that alone will save a life.
Absolutely. And we're talking about removing barriers. How do all of us leave here today feeling comfortable that if someone passes out, we know that we'll step in. We're protected by Good Samaritan laws. You can't come into any legal problems from harming someone. You know, if you're doing the chest compressions and they get an injury, you are protected from that. The best thing you can do is save the life for that individual and for their family. And just knowing that those breaths really weren't that effective and aren't a big part of it, I think really emboldens me and emboldens so many people to feel a lot more comfortable stepping in.
Rachel, and I just wanted to bring up this one additional point, because I think it's very important to bring up. Women, on average, will have higher rates of death in the community from lack of bystander CPR, because folks tend to have lots of hesitancy around delivering, just based on the anatomy, and not wanting to be criminalized or penalized for delivering CPR care. There's lots of hesitancy surrounding delivering CPR care to women. And that's a stigma that we need to break. If anyone needs CPR, care, cardiac arrest victim, we have to be comfortable enough to know that this patient's life, this victim's life, might actually be in your hands, and you have to feel empowered to deliver that care, regardless of who that patient is, and knowing what the status quo is, especially for women victims of cardiac arrest.
Yeah, thank you so much for that point. So let's jump into a quick demonstration video of how to do this.
If you see a teen or adult suddenly collapse, it is important to act fast. Helping to save a life is easier than you might think. Just start hands-only CPR. The first step is to ask someone to call 911 and to get an AED, or call 911 yourself and put your phone on speaker mode so the operator can assist you. Then get directly over the victim. Put the heel of one hand in the center of the chest and put your other hand on top of the first. Then push hard and fast in the center of the chest until help arrives. It's important to push, giving 100 to 120 compressions per minute, which is about the same tempo as the song Staying Alive, or the rate of music you're listening to right now. Let's hope you never have to use hands-only CPR. But know that CPR combined with using an AED provides the best chance of saving a life. If possible, use an AED every time you provide CPR. Again, if you see a teen or adult suddenly collapse, don't be afraid to start hands-only CPR. Remember, call 911 and ask someone to get an AED. Then push hard and fast in the center of the chest until the AED and help arrives. Your actions can help save a life.
That was great. I'm glad I didn't have to sing the Staying Alive song. Thanks for bringing that video up, Rachel. So that was great. So as I said, the biggest thing here is the 911, getting help, making sure that help is on the way, and then pushing hard and fast, center of the chest. And I know for some, this is the first time you're hearing this. For others, you may have heard this before. the more times you hear it, the more it will sink in. And God forbid the situation were to arise that you need to do this, right? You'll feel a little bit more comfortable. Luckily, having 911 on speakerphone as well will be another resource that will help you help guide you through CPR delivery. So that's something essential to make sure that you do when you're providing care.
Absolutely. Well, we are pretty much at time. We have one question I'd love us to take a second for that came up in the Q&A, and unfortunately, we are not going to have more time for additional questions, but I'll share how we can continue the conversation after Dr. Brown answers this question. So this question was, if an AED is not available, do you just continue compressions until help arrives, or do you take some pauses every now and then?
Yeah, so this is why help coming and help being on the way is important. If you're in a location, it could be sort of on the road, walking on the sidewalk, you're not going to have an AED next to you, right? So making sure that help is on the way is crucial, because over time, you will start tiring out, right? You want to continue delivering CPR. But over time, you will start tiring out, and the level of CPR that you're going to give over time will start diminishing. And that's why help coming and being on the way is crucial. If you need to take 1 or 2 seconds or a couple seconds break just to regain some momentum, then take that break and jump right back in. But it's important to really, really keep that CPR going. Luckily, I think Boston does well compared to other cities. The time between calling EMS and them arriving is somewhere around 8 minutes or so. So hopefully this shouldn't be more than 10 minutes delivering the CPR. But when we do our training, folks usually get tired at that 5-minute mark. I get tired. In the hospital, we've actually devised special compressors, right, to press on the heart, especially overnight when, the staff might be, the amount of staff that we need around might not be there. And having that compressor really goes a long way. If there's someone else around you, it's important to take turns. So maybe put on a timer, and every 2 minutes, you sort of cycle in and out. After they get the AED, and just make sure that effective compressions are being delivered. And if you want, you can cycle out every 2 minutes. If you're alone, unfortunately, you're just got to keep going until help arrives.
Well, Dr. Brown, I just thank you so much for joining us. Thank you for sharing all of your knowledge and for the work that you do alongside the Heart Association. And I want to thank everyone who joined us today, all of the companies who gave this time to your employees, all of those of you who, just took this chunk of time, hopefully over your lunch, over a chance to rest and just learn about something really critical in our community. We will be sharing later today to every email address as you registered for this. We'll be sending out a whole bunch of resources, including the video that we shared in this presentation, resources to where you can look up a certification if that's something you choose to do. And that will also be coming directly from my email address. And so that if there are any questions for Dr. Brown or for our Heart Association team in community impact or any level of the organization, I will be happy to share that out with the correct person and get you connected so we can continue the conversation. But thank you all for joining us, and we wish you all just a happy new year and a happy holiday season.